It starts the way it always starts. Somewhere between the second bite and the third sip, something shifts. A warmth begins to rise, not from the food, but from somewhere deeper. Behind the breastbone, a slow heat builds, climbing upward like smoke through a chimney. And in that moment, a familiar question returns. Is this just dinner? Or is this something else entirely?
Walk into any pharmacy, anywhere in the world, and the evidence is impossible to miss. Rows upon rows of antacids and acid blockers. 1 in 5 adults in the Western world deals with this condition regularly. That is not a niche problem. That is a global epidemic hiding in plain sight, one that most people never think of as a real disease. To understand why this matters, you need to understand what the stomach actually produces. Hydrochloric acid at concentrations strong enough to dissolve metal. A pH that can dip as low as 1. This is one of the most corrosive environments in the entire human body, and it exists by design. The stomach needs this acid to break down proteins and kill bacteria. The question is, what happens when this acid ends up somewhere it was never meant to go?
The esophagus is lined with a thin, delicate tissue called squamous epithelium. It is soft, it is sensitive, and unlike the stomach, it has no protective armor, no thick mucus barrier, no chemical shield. It was built for one job only, to move food downward. It was never engineered to survive a chemical attack.
Standing between these two worlds is a ring of muscle at the base of the esophagus, the lower esophageal sphincter. Think of it as a gatekeeper, a living seal that opens to let food through, then snaps shut to keep everything below where it belongs. When this gatekeeper works, you never think about it. When it fails, everything changes. In GERD, the gatekeeper relaxes at the wrong time. These involuntary openings, called transient lower esophageal sphincter relaxations, allow stomach acid to surge upward into the esophagus. It is not a dramatic event. There is no warning. The sphincter simply lets go, and acid floods into a space that has absolutely no defense against it. The moment acid contacts the esophageal lining, the chemistry of damage begins. The tissue swells. Blood flow increases as the body rushes immune cells to the site. Nerve endings fire. And deep within the chest, a burning sensation takes hold, one that millions of people around the world know all too well. This is heartburn. But what is actually happening goes far beyond discomfort.
When reflux happens occasionally, the esophagus can recover. But when it happens day after day, week after week, the damage starts to accumulate. Redness appears first. Then the surface cells begin to break down, forming shallow ulcers. Under an endoscope, these early erosions reveal the first physical evidence that something is going wrong. If the reflux continues unchecked, the erosions deepen. They spread upward from the junction where the esophagus meets the stomach, forming patterns that physicians sometimes describe as flame-shaped streaks. In severe cases, these wounds can bleed. They can cause pain so sharp and so sudden that it becomes indistinguishable from something far more frightening. Every year, emergency rooms around the world see patients convinced they are having a heart attack. The chest pain is crushing. The fear is real. But after the EKG comes back normal and the cardiac enzymes are clear, the answer turns out to be acid reflux. GERD can mimic cardiac chest pain so convincingly that even experienced clinicians must rule out the heart before looking at the esophagus. And then there is something truly remarkable. In some patients with years of chronic reflux, the esophageal lining does something it was never supposed to do. It transforms.
The normal flat cells are gradually replaced by taller, mucus-producing cells that resemble the lining of the intestine. This is called Barrett's esophagus. It is the body's attempt to adapt to an environment it cannot escape. But this adaptation carries a cost, because these new cells have an elevated risk of becoming cancerous.
Not everyone with GERD feels the classic burn. Some people experience it as a persistent tightness in the throat, a sensation that something is stuck, even when nothing is there. It can linger for hours, quietly disrupting conversations, meals, and concentration, without ever announcing itself as a digestive problem.
Acid does not stay in one place. It travels. It can reach the vocal cords and cause chronic hoarseness. It can trigger a cough that refuses to respond to standard treatments. It can erode tooth enamel from the inside out, leaving damage that a dentist can see, but that the patient may never connect to their stomach. These are the hidden faces of GERD, the symptoms that send people to specialists who may never think to look below the chest.
And here is the paradox that has puzzled researchers for years. Some patients experience intense, unrelenting heartburn, yet when their esophagus is examined, it looks completely normal. No redness, no erosion, no damage at all. The pain is real, but the tissue has not caught up. Current science suggests that in these patients, the nerves themselves are hypersensitive, firing alarm signals in response to acid levels that a normal esophagus would barely register. This is what makes GERD so much more than simple heartburn. It is not one disease with one presentation. It is a spectrum shaped by anatomy, chemistry, nerve sensitivity, and time. And understanding that spectrum is the first step toward understanding what comes next. Certain foods have earned their reputation for a reason. Fatty meals slow the stomach from emptying. Chocolate contains compounds that directly relax the sphincter. Coffee stimulates acid production. Citrus and tomato add acidity to an already irritated lining. Alcohol hits on multiple fronts at once. For many people, dinner is where the trouble begins. Carbonated beverages introduce something the stomach does not need: gas. That gas has to go somewhere, and the body's preferred escape route is upward, through the sphincter. Each burst of carbonation provokes the very relaxation events that allow acid to breach the barrier. The fizz in the glass becomes pressure in the stomach, and pressure is the enemy. Gravity is one of the body's most underappreciated allies against reflux. When a person is upright, acid stays pooled low in the stomach, held in place by simple physics. But the moment the body goes horizontal, that advantage vanishes. The stomach and esophagus become level, and even a minor sphincter relaxation can send acid flooding into a space where it will sit for minutes or even hours, unchallenged. This is why nighttime is the danger zone. The body is asleep, but the stomach is still working. The sphincter relaxes in the darkness, and acid begins its slow upward migration into a horizontal esophagus. There is no swallowing to push it back. There is no gravity to drain it away. For many people, the worst damage happens while they are completely unaware. It does not take much. Bending forward to tie a shoe, a tight belt cinched around the waist. These everyday movements compress the abdomen and push the stomach's contents upward. The human body was not designed for a world of desk chairs and restrictive clothing, and the esophagus pays the price for postures and pressures that seem completely harmless. Of all the modifiable risk factors for GERD, excess body weight stands above the rest. Abdominal fat creates constant upward pressure on the stomach, squeezing its contents toward the esophagus like a hand tightening around a tube of toothpaste. Research has shown an almost linear relationship. The more weight around the midsection, the more frequent and severe the reflux. And weight loss remains one of the most effective interventions available. A hiatal hernia changes the anatomy of the problem entirely. Normally, the diaphragm reinforces the sphincter from the outside, like a second lock on a door. But in a hiatal hernia, the upper stomach slides upward through the diaphragm and into the chest cavity. The sphincter loses its backup, and a small pouch forms above the diaphragm where acid can pool, creating a reservoir of trouble right at the doorstep of the esophagus.
Pregnancy creates a perfect storm for reflux. Rising progesterone relaxes smooth muscle throughout the body, including the sphincter. As the baby grows, the expanding uterus pushes the stomach upward and compresses it from below. Up to 80% of pregnant women experience reflux symptoms. For most, it resolves after delivery. But for some, it reveals a vulnerability that was always there, waiting.
Risk does not arrive all at once. It accumulates. Smoking weakens the sphincter and reduces the saliva that helps neutralize acid. Certain medications relax the barrier as a side effect. And with each passing decade, the sphincter gradually loses its tone. The esophagus clears acid more slowly, and the window for damage grows wider. GERD is often a condition of compounding vulnerabilities. Here is a fact that often surprises people. GERD does not always get worse. Most patients remain stable for years, sometimes decades, at whatever point on the spectrum they started. Only a minority progress from mild reflux to erosive disease, and the transition from Barrett's esophagus to cancer is rarer still. The trajectory of GERD is not a straight line toward catastrophe. For most people, it is a plateau. But even without progression, GERD reshapes daily life in ways that are difficult to appreciate from the outside. A restaurant menu becomes a risk assessment. Every meal is a negotiation between what sounds good and what the body will tolerate. The spontaneity of eating, one of life's simplest pleasures, is replaced by a constant internal calculation that never fully turns off. Sleep becomes strategic. Raising the head of the bed by 6 inches, not with pillows, but with blocks under the frame, changes the angle of the esophagus just enough to let gravity do its work. Sleeping on the left side keeps the gastroesophageal junction above the acid pool. These are not folk remedies, they are measurable physiology, and for many people, they are the difference between rest and misery. One of the most important discoveries in GERD research is the acid pocket. After a meal, the stomach's contents form layers. Food settles below, partially buffering the acid. But above the food, near the top of the stomach, a layer of unbuffered, highly concentrated acid collects. This pocket sits right at the entrance to the esophagus. In patients with a hiatal hernia, it can migrate above the diaphragm, placing concentrated acid in direct contact with vulnerable tissue, even without a full reflux event. Not all reflux is created equal. In some patients, bile acids from the small intestine flow backward into the stomach and then up into the esophagus alongside hydrochloric acid. This combination is especially destructive because bile can penetrate cell membranes in ways that acid alone cannot. Mixed reflux has been linked to the development of Barrett's esophagus and may explain why some patients continue to suffer even when their acid levels are well controlled. And then there is the brain. The esophagus is densely wired with nerve fibers, and how much pain a person feels depends not only on how much acid is present, but on how the nervous system interprets the signal. Stress, anxiety, and sleep deprivation can all lower the pain threshold, making the same reflux event feel dramatically worse. The perception of GERD is shaped by chemistry and neurology in equal measure. When clinicians talk about primary GERD, they mean reflux caused by the body's own mechanical failure, a sphincter that does not hold its tone, peristalsis that does not clear efficiently, an anatomy that simply was not built to keep acid where it belongs. In primary GERD, there is no external disease to blame. The reflux barrier itself is the problem, and it may have been compromised from the very beginning. But reflux can also be driven by something else entirely: In scleroderma, fibrosis stiffens the esophagus until it can barely contract. In gastroparesis, the stomach fails to empty on schedule, staying full and pressurized for hours. In Zollinger-Ellison syndrome, tumors flood the stomach with acid far beyond normal levels. In each of these cases, GERD is not the primary disease. It is a consequence, and treating the reflux alone will never be enough.
Between primary and secondary GERD lies a gray zone that most patients actually inhabit. A mildly weak sphincter that would cause minimal trouble under ideal conditions, pushed past its threshold by weight, by smoking, by medications, or by habits that slowly accumulated over years. For these patients, reflux is not destiny, it is context, and that context can often be changed.
The first step in diagnosing GERD is often the simplest. A physician prescribes a short course of a proton pump inhibitor and waits. If the symptoms improve significantly, the diagnosis is supported without a single invasive test. The response to treatment becomes the evidence. It is practical, cost-effective, and for many patients with straightforward reflux, it is all that is needed. When symptoms persist, or when warning signs appear, the investigation goes deeper. An endoscope, a flexible tube with a camera and light, is guided through the mouth and down the esophagus. It allows a physician to see the lining directly, to identify erosions, ulcers, or the telltale color change of Barrett's esophagus. But endoscopy has a well-known blind spot. A normal-looking esophagus does not rule out significant disease. For cases where the picture remains unclear, a tiny wireless capsule can be attached to the esophageal wall. It sits there for days, silently recording every reflux event, measuring the exact pH at the lining, tracking the timing, the duration, and the relationship between acid exposure and symptoms. This is ambulatory pH monitoring, and it captures the truth of what is happening inside the esophagus over the course of real daily life. Esophageal manometry adds another dimension. It measures the pressure and coordination of the muscular contractions that move food downward. It reveals whether the esophagus is clearing acid efficiently, whether the sphincter is generating adequate pressure, and whether a motility disorder might be contributing to the problem. Together with pH data and endoscopy, it builds a complete functional portrait of the reflux barrier. The foundation of GERD management is not a pill. It is a set of choices. Smaller portions, earlier meals, maintaining a healthy weight, identifying personal trigger foods, which vary far more from person to person than most lists suggest. These adjustments may seem modest, but for patients with mild to moderate reflux, they can reduce symptoms more reliably than many people expect. When lifestyle changes are not enough, pharmacology steps in. Antacids provide fast but brief relief, neutralizing acid that has already been produced. Histamine 2 blockers take a different approach, reducing acid secretion at the source by blocking one of the chemical signals that drives the stomach's parietal cells. Both have their place, but neither offers the sustained suppression that chronic GERD often demands. Proton pump inhibitors changed the landscape of reflux management. They work at the final step in acid production, locking onto the hydrogen-potassium pump on the surface of parietal cells and shutting it down. The result is a reduction in stomach acid output of up to 90%. For millions of patients, a daily PPI is the single intervention that makes GERD livable. It heals erosions, controls symptoms, and prevents relapse. But the question of long-term use remains open. Decades of daily acid suppression have raised concerns about nutrient absorption, infection risk, and other potential consequences. The clinical significance of these associations is still debated, but the conversation has shifted toward a guiding principle. Use the lowest effective dose for the shortest necessary time. Chronic medication always involves a balance between benefit and uncertainty. For patients who cannot achieve adequate relief with medication, or who prefer not to take pills indefinitely,
Surgery offers a structural solution. In a fundoplication, the upper portion of the stomach is wrapped around the lower esophagus and sutured into place, creating a reinforced barrier from the outside. It is an engineered fix for a mechanical problem, and in carefully selected patients, it can provide durable relief for years.
When Barrett's esophagus is detected, the goal shifts from managing symptoms to preventing cancer. Endoscopic techniques now allow physicians to treat precancerous tissue directly. Radiofrequency ablation delivers controlled energy to the abnormal lining, destroying it so that normal cells can grow back. It is a targeted intervention that has dramatically improved outcomes for patients caught early in the progression. The future of GERD treatment may reach beyond the stomach entirely. The growing understanding of how the brain and the gut communicate, how stress amplifies symptoms, and how the nervous system modulates pain has opened entirely new avenues. Neuromodulators, cognitive behavioral therapy, even hypnotherapy have shown promise for patients whose reflux defies conventional treatment. The next chapter of this story will be written at the intersection of gastroenterology and neuroscience. Gastroesophageal reflux disease is easy to dismiss. It is common. It is familiar. It lacks the dramatic weight of conditions that make headlines. But beneath that familiarity lies a condition of genuine complexity, one that involves failing muscles, misplaced acid, rewired nerves, and cells that change their identity under pressure. GERD is not simple heartburn. It is a window into how the human body negotiates between function and failure, and it deserves to be understood, not just endured.